So this was a CTA.
Whoa.
And so for my residents, what do you guys think about this aneurysm here? I'm going to try to window it a little bit more. What kind of aneurysm do you think this is? Yeah, exactly. So Kevin was saying maybe this is a mycotic aneurysm. So it doesn't look fusiform. It's like very saccular. It's outpoaching off of like a relatively normal looking aorta. And then if you go, you know, like this here looks kind of like heterogeneous, soft tissue. There's like a little bit of stranding around it. So this is actually very concerning for a mycotic aneurysm or infected aneurysm. The term mycotic used to mean, it means like mycosis, which is mushroom. It doesn't mean that this is a fungal infection, but it looks like a mushroom cap coming off the aorta. The patient had like fever, elevated ESR. So the treatment for this is that they traditionally, they used to go for surgical intervention. But now they're doing more endovascular repair of these. And so they endovascularly stented across this aneurysm. And actually then they put some stents into the celiac axis and SMA. And then afterwards, we did a CTA to make sure there was no leak here, which I'll show you. And then they asked us to put a drain into this mycotic aneurysm, which was a new request from in my experience. And so but it turns out there's a bunch of papers coming out about this. So this is actually endovascular repair is much less invasive and does actually better than, you know, if you go in and you have this whole infected area and you're putting a stent in. Either way, if it's open or endovascular, the stent is going to be exposed to infection. So either way, you have a very high risk of infecting the stent and having chronic infection. So you need to treat it rapidly. You have this, and then you have to like basically treat the infection. Openly, you might be able to debride it, but you might not get all the infection out. So they've been doing this now with endovascular repair with a drain. And so my vascular surgeon sent me a bunch of articles about it. So this was the follow-up CTA. You need to do a CTA before you put the drain in because you want to make sure there is no endo leak. Because obviously if there's a leak to that aneurysm still, you don't want to stick a drain into it. Sorry, I'm getting down to the area. It's a lot of images. Okay, so this is the post-op. There's a stent there. The aneurysm has been excluded. There was no leak. And then you can see that they also put like a snorkel. They put some stents across there as well into the SMA and the celiac axis. And then they asked us to put a drain into this area here. Oops. So it's just like any other drain. Oops. Sorry, it's going slowly, but basically, just like any other drain. So basically we're trying to stay like outside of the pleura. So there's an effusion here. So we tried to stay extra pleural and then put the needle and the wire in there. And then, long story short, we put a drain into the mycotic aneurysm. So this was something that, let me see. In the end, there was the wire. And then there's the drain. And then afterwards, the patient's white count dropped dramatically and is now normal. And so they were very grateful that we put the drain in. It was putting out some purulent material. It did not grow any microorganisms, but it probably still was infected, and maybe the antibiotics had kind of penetrated the area, which is why it wasn't growing. But yeah, so this is a drain of a mycotic aneurysm. You can do this if they place a stent and you have a residual sac, because you don't want that stent sitting in an infected sac.